Thank you. So thanks so much, everyone, for being here. Thanks so much to all of our co-sponsors. This time around, we didn't manage to get EU sponsorship, but we did have quite a few of EU member states who agreed to co-sponsor our side events. I'm really grateful for the support, and also it's for us to show support for civil society engagement as well. I think it's important in this shrinking civil society space we're all facing these days. So we're organizing this side event. We're organizing this side event because we wanted to talk about good practice examples, but also some challenges we're facing in the area of public health and drug policy. So the EU has a very long experience in promoting a balanced approach to drug policy that aims to promote demand reduction, supply reduction, harm reduction, international cooperation, as well as an approach that is grounded in evidence and human rights. The EU is also committed to civil society engagement. By the way, my name is Marie Lucie. I am the head of research and communications, but I am here representing the EU Civil Society Forum on Drugs. And the Civil Society Forum on Drugs is the expert committee of the European Commission on drugs. So it's a mechanism that was established to ensure civil society participation and community participation in the EU debates on drug policy. So it's in and of itself, it is a good practice example of how mechanisms like these can be established at regional level to ensure systematic civil society participation in the debates. But as in most regions of the world, I think what we're facing in Europe also is a securitization of drug policies. We're witnessing this shift. We're also witnessing a funding shortage for civil society, for services for people who use drugs, and a deprioritization of health and human rights. And so at this important juncture, what we really wanted to showcase here is some of the work of civil society forum members to try and challenge this securitization narrative, but also to showcase examples of good practice from their country or the region in terms of promoting a rights-affirming approach to drug policy and also promoting the meaningful participation of people with lived and living experiences. So that's why we're here today. I hope this conversation is going to be interesting. Before I pass on to our panelists, I wanted to give the floor to Stig Erik Sorheim from EURAD. Every year we have a different CSFD member leading on the organization of our CSFD side event because we don't have a cost of accreditation. So this time around, EURAD took up the challenge. So Stig Erik wanted to say a few words of welcome to all of you.
Well, yes, that's what I was going to do. Just welcome you all on behalf of the Civil Society Forum. EURAD is a member, and I'm a member of the core group. So we are very happy to host this on behalf of the Civil Society Forum. We support the balanced approach to drug policy, like pretty much everybody, but we need to remind everybody that the balance, there needs to be a balance. And there is a tendency that the drug control and the security aspect gets a lot of attention. So we are here to remind everybody that it's also a matter of health, or perhaps primarily a matter of health. If you look at the conventions, it's to protect the health and well-being of mankind. That's the purpose. And law enforcement can best be a tool. It's not a goal. So that's what I want to say.
Thanks so much, Stig Erik. Sorry, and now without further ado, I'd like to pass the floor to our first panelist, and I'm very grateful that you're here today. So Lucie Laffont is representing the European Commission, and as many of you might know already, the European Union has adopted a new strategy on drugs. So we've asked Lucie to talk a bit about its contents, but also talk specifically about the health-focused approach within that new strategy. So Lucie, you've got the floor, and many thanks for being here today.
No, thank you very much for inviting us. It's very important for us as the Commission to support the CSFD side events and civil society more generally. So as you mentioned, we adopted in December 2025 a new EU drug strategy, which aims to respond to the challenges that are posed by drug use in relation to health within the EU. We see notably drugs being increasingly potent and addictive, which pose a risk to health, but also social stability and environmental degradation. We also see cocaine consumption rising and new forms of use of new psychoactive substances, which are emerging, and the risk of poisoning and overdose, which are very serious. So these are all these issues that the strategy is aiming to tackle. So the strategy is balanced and comprehensive. It aims to protect citizen well-being and public health, and also to strengthen security responses and to step up international cooperation and partnerships. It aims to strengthen Europe's preparedness against serious threats to health and security. With this strategy, the Commission shows its commitment to a multidisciplinary and balanced approach to drug policy, integrating security, health, and social measures with a person-centered approach. The purpose of the strategy is to shape drug policy at EU and national levels and inform EU engagement internationally. It promotes a whole-of-society approach, which is very important, to strategy to strengthen sectoral and partner cooperation and actively engaging with civil society. The strategy takes a result-oriented approach, which means that it proposes some concrete actions that will be implemented with the support of all the relevant stakeholders. And the way we drafted the strategy was actually a collaborative process with the member states as part of the Council of the European Union, but also with the civil society, in particular with the Civil Society Forum on Drugs, with whom we also had consultation and was quite involved in the whole process. The strategy is accompanied by a dedicated EU action plan against drug trafficking, which builds on the priorities of the strategy and take an action-oriented approach to disrupt organized criminal networks behind drug trafficking, targeting their routes and criminal methods. So this action plan is a bit more security-oriented, but it still reaffirms also the human rights approach and the balanced approach of the drug policy within the EU, and also including action on crime prevention and drug-related violence, for instance. So the strategy was endorsed by the EU member states in the Council last week. It contains 5 strategic pillars. The first one is to enhance EU and national preparedness to anticipate and respond to drug-related health and security threats. Second one, to protect public health. Third one, to improve security and protect society. The fourth pillar is to address risk and harms related to drugs. And the fifth one is to build strong partnerships both at the EU level, but also internationally, and throughout all the other pillars of the strategy. So as you can see, 2 of the strategic pillars of the strategy specifically focus on the health-related aspect and harm reduction aspect of the drugs policy. The strategy aims to strengthen the health resilience and reduce drug use via evidence-based and preventive approaches, with enhanced treatment, recovery, and reintegration, as well as through mental health resilience and targeted support to vulnerable groups. And well, this aspect is also very important in the resolution that is being negotiated, that was tabled by Finland and Norway, focusing on the public health approach, and so this is we find synergy also with our drug strategy. It also aims to protect the individuals and communities against drug-related harms. This includes measures addressing individual health, for example, aimed at reducing the risk of drug overdoses and of infection, but also social and environmental damages, notably by addressing drug-related violence, stigma, and the ensuring the safe disposal and distribution of seized drugs. As part of those efforts, the Commission will also encourage member states to step up support for recovery, housing, mental health assistance, and job opportunities for individuals affected by drug use, reducing social exclusion and promoting human rights. The Commission will step up its work on preventive health through initiatives on cardiovascular disease and mental health under the Healthier Together EU non-communicable disease framework. And this approach aids in reducing drug use and bolstering mental health resilience against substance use disorder. The Commission supports the Member States with a comprehensive approach to mental health through a dedicated communication, focusing on vulnerable groups and health inequalities. We also work very closely with the EU Drugs Agency, as is here. So obviously the agency is very key and will be very key in implementing the EU drug strategy. And notably will help member states to develop effective awareness-raising activities targeted at priority areas, including cocaine use and potent new synthetic drugs. The EUDA will also support these efforts by assessing the quality of intervention at national, regional, and local levels, and developing an EU-wide comprehensive guidance on quality standards. The strategy calls on member states to improve reintegration of people with drug use disorder into the community and the labor markets, and this helps to reduce drug use and the risk of relapse after treatment. To contribute to those efforts, the Commission will promote the socio-economic integration of people in vulnerable situations, including people using drugs, through current and future EU spending instruments, such as the European Social Fund Plus and the European Regional Development Fund, or the proposed national and regional partnership plans beyond 2028. The UDA will also roll out a new learning platform called Plato 2.0, under which expanded and tailored e-learning possibilities on social reintegration will be made available. And finally, the strategy recognizes the need to reinforce meaningful engagement with civil society. At the EU level, I already mentioned, but we have the Civil Society Forum on Drugs, which will remain an integral part of the implementation of the strategy. EUDA will also enhance its regular collaboration with civil society as part of the expanded mandate that was adopted 2 years ago. Thank you.
Thanks so much, Lucie, for your presentation and for this comprehensive overview of the EU framework. I think for us as the CSFD, we'll continue being engaged in the implementation of the strategy, and in particular, and something we've been pushing for a lot is the development of an action plan that covers all aspects of the strategy and not just the drug trafficking aspect. Because obviously, if we have no action plan, it's difficult to evaluate and to track progress against. So our next speaker is Magdalena Dabkowska from the Helsinki Foundation for Human Rights in Holland. So Magda, thanks so much for being here with us today. And Magda is going to tell us a bit about some of the key challenges that we're facing in the region in terms of ensuring the right to health.
Thank you very much. Thank you for the possibility to be here. Distinguished delegates, dear colleagues in the room and joining us online. Helsinki Foundation for Human Rights that I work for is, as Marie mentioned, a Poland-based organization, one of the biggest and oldest human rights NGOs in the region. And we identify ourselves as a watchdog type of an organization whose role is to monitor the human rights situation and to be vocal about the identified problems, challenges, and finally violations. And this is the perspective that I'll be speaking from today. And that makes me start from noting that although the EU as a whole has for years been recognized and praised for its balanced drug policy with a strong emphasis on health, on public health and human rights, at the national and sub-regional level, there are still challenges undermining the right to health approach to drug policy. And there are also worrying signals at the European level. So since we are today focusing on the right to health, let me remind us about the basics. And to do so, I will read just a couple of sentences from the webpage of the World Health Organization. The right to health and other health-related human rights are legally binding commitments enshrined in international human rights instruments. Every human being has the right to the highest attainable standard of physical and mental health. Countries have a legal obligation to develop and implement legislation and policies that guarantee all universal access to quality health services and address the root causes of health disparities, including poverty, stigma, and discrimination. The right to health is indivisible from other human rights, including the rights to education, participation, food, housing, work, and information. And these constitute the group of so-called economic, social, and cultural rights. And actually last year, the Eurasian Harm Reduction Association, together with Helsinki Foundation for Human Rights, published a report on how drug policies affect the enjoyment of these economic, social, and cultural rights, including the right to health, by people who use or used drugs in the region of Central and Eastern Europe and Central Asia. And there are two types of challenges that we identified. Those related to the healthcare system and those all around it that influence the ability to benefit from existing possibilities. Over-reliance on the justice system, the punitive laws and practices of law enforcement agencies hinder access to and benefits from health-focused interventions where they exist. Namely, criminalization of drugs possession contributes significantly to the barriers, including legal, administrative, and psychological ones that discourage people who use drugs from accessing care and treatment services. If police officers stand in front of the OIT or harm reduction facility, you will think twice before you decide to enter. If by admitting that you identify any problems with your drug use, you may lose your parental rights or social state support, it is probable you will never decide to reach for healthcare or treatment possibilities. People who use drugs frequently experience stigma and discrimination, including in the healthcare settings, leading to denial of care, biased treatment, and inadequate attention to co-occurring conditions like AHV and hepatitis C. Even though they're highly susceptible to infections like AHV, hepatitis C, and TB, people who use drugs face bureaucratic and discriminatory barriers to receiving timely diagnosis and treatment. Access to harm reduction services such as OAT, needle syringe programs, take-home naloxone remains inconsistent. In rural areas, these services are either severely limited or non-existent. Furthermore, bureaucratic restrictions and lack of funding often result in significant service gaps even in urban areas. OIT programs are sometimes burdened by restrictive conditions such as daily attendance requirements, which disrupt patients' lives. Take-home dosing options are limited, affecting flexibility and access to consistent treatment. Specific needs of societal groups such as women, youth, LGBTQI people are not necessarily met, and in many places, treatment and healthcare services are not tailored to these needs. Women who use drugs face stigma and discrimination in reproductive and maternal health care, discouraging them from seeking care due to fears of poor treatment and child custody implications. AHV positive status makes it more difficult to qualify for some medical procedures, for example, in vitro. The mental health needs of people who use drugs are frequently overlooked. And finally, the access to healthcare in prisons. People who use drugs deprived of liberty face challenges in accessing healthcare services, including limited or no harm reduction, OAT, and discontinuity of care upon entering or leaving prisons, leading to health deterioration. So this is a good place to actually warmly welcome the decision of the Cyprus presidency to make the comprehensive health services in prisons a thematic priority for these 6 months. So while I'm sharing findings of the study conducted in CE, the identified gaps and challenges are not necessarily limited to this part of Europe or to the world more broadly. Being at the CNT, we'll all recognize the mutual influence and global interdependence that affects all of us. The EU strategy, for example, which has traditionally guided member states' policies and agendas, can also be of an interest for non-EU countries, the neighboring states, or EU overseas partners. It can serve as a reference point for those undergoing the accession procedure. And actually, tomorrow at 3 p.m. we have a side event about that. So please feel warmly invited to join us. Understanding this importance, civil society across the EU feel, and I can say that we also share this belief between CSFD members, that we need to preserve the evidence-based, health-oriented, human rights-rooted approach, which the previous EU drug strategy represented. The new document is disturbingly upsetting the balance between the health and security approaches to drugs in favor of the latter one. So we still count on the action plan or another more technical document of this level that would actually, again, bring all these pillars together and in a bit more balanced way. But even with a strong security component, as it was yesterday presented at the side event by the EU representative, citizens' well-being and public health are meant to be in the core of the strategy. But we must not forget that people who use drugs are EU citizens too. We must never forget that it's their life, their health, well-being, and finally, their safety and dignity that should also be protected by the European and country-level laws and strategies and should not be threatened by how they are enforced. As it was rightfully stated yesterday, public authorities will not succeed alone. Partnering up was highlighted several times and the role of civil society stressed, but apart from the words of appreciation, a bold, strategic, and practical attitude is needed. We have to be serious about space for civil society shrinking year by year, with funding shortages being a strong manifestation of this sad reality. In times of budget cuts and austerity measures, the financial resources follow the security priorities and melt for health interventions and the civil society groups and organizations providing support, care, and treatment to people who use psychoactive substances. And thus, without proper funding and a framework allowing those who act on the ground do the work, the enjoyment of the right to health will continue to be undermined, and for a number of vulnerable groups will be very limited. I do have a number of recommendations, but I guess I'll keep them for another round.
Sounds good. Thanks so much.
From what I said, you can already, I think, guess what the recommendations I would share. Thank you very much.
Thank you so much. And we can always go back. We'll have some time for Q&A, so we can also go back to the key recommendations we want to bring forward here. But before that, I want to give the floor to Leo Jefferys from the European Network of People Who Use Drugs. And for us, for the side events in particular, we really wanted to put the lives and the experiences of people with lived and living experiences front and center into these debates. So Leo, you've got the floor, and we have you're able to put up this presentation. Thank you.
Thank you. Colleagues and distinguished delegates, thank you for having me speak to you today. EuroInput, the European Network of People Who Use Drugs, is the regional drug user network fighting for the health and human rights of people who use drugs in Europe and its neighboring countries. There is a growing gap between the European Union's stated commitment to health, dignity, and inclusion and the reality of drug policy on the ground. As people who use drugs, we are still fighting for our definition of health. No.
All right,
Our definition of
Still
health.
fighting at the PowerPoint.
Yeah. Next slide. So now, there we go. Definition of health. So we're still fighting for our definition of health and recognition of our basic human rights. People who use drugs across all jurisdictions are being denied full rights of EU citizenhood, including the right to health and the right to life. The unstable drug market and toxic supply poses an immediate risk with hospitalizations due to synthetic cannabinoids, non-opiates contaminated with nitazines, and new contaminants with each scheduling of the last. This is not sustainable. Comparing regulated substances like alcohol, if suddenly contained gasoline similar to alcohol under prohibition, there would be a full institutional health response, not the criminalization of people who drink alcohol. This health emergency impacts people who use drugs, but also puts pressure on local and national health systems. We must push for a commitment from policymakers to a social-led response, with safer supply being the ultimate goal. A prototype of safer supply is agonist treatment, but barriers to accessing OMT still remain. Recent 2025 research by EuroInput members found 91% of study participants in Lithuania, Poland, and Czechia experience one or several barriers to OMT for access for women and gender diverse people. Drug checking is a health-centered policy in practice. When privileged access of living experience is excluded from monitoring, EU early warning systems and preparedness is weakened. Costs of response and deaths increase. You cannot monitor contaminants through seizure, wastewater analysis, or post-mortem toxicology. Drug checking is the only mechanism which acts in accordance with Article 2 of the European Convention on Human Rights, the right to life, and is a recommended policy tool in the 2024 report of the Special Rapporteur on drug use, harm reduction, and the right to health. Access to naloxone remains restricted in most of Europe. A central message from the EU to member states supporting prescription-free naloxone could have widespread positive implications. We can act now to save lives. Other examples in our definition of health include drug consumption rooms, the decriminalization of drugs, the opportunity to deregister old drug charge convictions, as seen recently in the 2025 cannabis legislation in Malta. These defining health initiatives scaffold our right to life and right to health and are built on trust between people who use drugs and our allies in civil society. over years of collaboration, and they can be taken away as quickly as removing a page in a strategy. As civil society members, networks like EURAD rely on trusted relationships with other civil society organizations, and if this space shrinks, so does our meaningful engagement in policy that shapes our lives. The exclusion of people who use drugs from policy design and implementation has had devastating effects. Policies developed without meaningful participation of those most effective are more likely to miss emerging risks, lack legitimacy, and are less cost-effective in implementation. The removal of civil society and community-led harm reduction from strategy language, paired with the sole inclusion of abstinence-based recovery, is a thinly veiled communication that says to us, you're no good unless you're clean. You're no good unless you're only on 30 mils of methadone, and even then we'll make you wait outside at the clinic in the rain. The ongoing criminalization of people who use drugs is foundationally underpinned in the promotion of the capital R recovery agenda, because this agenda promotes not using drugs as the sole access to citizenhood, rather than looking at any positive change or simply that one exists. People who use drugs are full rights-bearing citizens, regardless of what we put into our bodies. As harm reductionists, drug users in our communities are often pitted against people in abstinence as some kind of us and them situation, when really it's competitive tendering, shrinking resources, and the status quo of moralistic systemic structures that prevents us from fighting together to protect our bodily autonomy, our right to health, and our right to life. Rights are being taken away from us by those that seek to capitalize on rather than cultivate our communities. Drug policy advocates who are out as being people who use drugs are constantly at risk of criminalization. We see a lack of uptake for involvement in drug policy and advocacy because of this fear of a loss of livelihood, loss of housing, the loss of family, including parents having their children taken away. To truly engage people who use drugs is to decriminalize the opportunity to engage. As Human Rights High Commissioner for Human Rights, Volker Turk, has emphasized, decriminalization is a crucial step toward treating people rather than punishing drug use. Moves towards decriminalization and regulation in parts of Europe show how legal reform can support health rather than undermine it. With decriminalization in Portugal and more recently in Germany and Malta, there is growing evidence for health-led legal frameworks that can free up resources redirected from overburdened justice systems, reduce violence, and improve access to care. A rights-based European drug policy cannot be achieved without the experiential expertise of people who use drugs. The most affected must be recognized as partners in shaping the policies and services that impact our lives. We want inclusion, ensuring people with lived and living experience are central in governance and planning as key stakeholders, as part of civil society, but also recognizing that people who use drugs are a special cohort of civil society with privileged access to issues and trends in real time. Moving forward, the challenge, the opportunity for Europe is to be brave, to protect and fund evidence-based health interventions. We demand recognition, recognizing harm reduction as part of public health systems and promote continuum of services. We want sustainable civil society funding in order to resource this continuum, including funding for drug user networks. To ensure our lives are safe from the failed approaches of prohibition, we need human rights-based drug policy. We want observation of our right to life, our right to health, and our right to life, and alignment of EU drug policy with human rights instruments. Thank you for having me speak to you today. I welcome any questions.
Thanks, Leo, and thanks for your bravery for speaking out in favor of the voices of people who use drugs. It's critical. We need it here. We need it in Vienna more than ever to try and break the silos between these rules that can often be very bureaucratic, very misaligned with what's happening on the ground. So I think your voice is absolutely critical and so helpful. We're going to move on to our next panelists. And Adelaide is going to put your presentation up in a second. But it's Rodrigo Coutinho from Arraiz do Pinhal in Portugal. And we wanted Rodrigo to present some silver lining, good practice example of his work at Arraiz do Pinhal that has been really trying to address the whole spectrum of services that people who use drugs or people who have drug dependence might need. So yeah, really happy for you to be here and to share your experience of many years, decades of work at ArcelorMittal.
Thank you, Maria. And condensed 40 years of work in 8 minutes is not easy, but I try to be.
Challenge is on.
Okay, good afternoon, everyone. First of all, on behalf of ArcelorMittal, I would like to thank the kind invitation of EURAD and Civil Society Forum on Drugs and congratulate for organizing this side event. I would also like to welcome my fellow panelists and everyone present in this room. It is a real pleasure to be here. It is. So, to put into context, between the early 80s and the early 2000s, for reasons that cannot be detailed here, Portugal was ravaged by what we might call a heroin epidemic. It is estimated that 80,000 to 100 young people have been involved in problematic heroin problems at some point in their lives over this period. Furthermore, during the early years, responses were very limited, as shown in the slide. Given this context, in 1986, a group of 4 psychiatrists, including myself, working in the psychiatry department of a general hospital in Lisbon, took the initiative to create a response that could give more consistency and continuity to the work done in this clinic. Thus, 40 years ago, ArcelorMittal, ADB, was created a non-profit NGO for social inclusion, which began with a therapeutic community for 12 people. And over the next 6 years, we created 2 more therapeutic communities, enable us to support a total of 55 people since 1992. In 1987, drug-related issues were transferred to the jurisdiction of the Ministry of Health, and there was a greater political and economic investment by the government to create more responses, namely dissemination of treatment outpatient facilities in most affected regions and cities of the country, launching of OAT programs in early 90s in public treatment outpatient facilities, agreements with residential long-term treatment centers, therapeutic communities, etc. But we must be noted that the drug-related strategy was mostly geared towards abstinence-oriented treatment and rehabilitation. Okay, that's it. I'm lost. In 1998, ADB was invited to take part of an urban reconversion carried out by the municipality of Lisbon of a rundown neighborhood, Casalvento, which was at the time the biggest illicit drug market in Portugal and the largest open-air consumption district in the city of Lisbon, and where we encountered a terrifying scene. More than 400 drug users lived there, and everybody shared drug consumption paraphernalia. The plan aimed to welcome, care for, and refer drug users who lived in improvised shelters in the vacant plots of the neighborhood, providing basic health care, food, hygiene, clothing, social care, and access to a low-threshold methadone drug. 98% of these people were heroin users, and 80% of them were intravenous users. It was the first outreach methadone program in Portugal. To see this slide, we can see the data of the enormous burden disease of this population. 61% were HIV positive, 79% HCV, 40% tuberculosis. It was weird. This plan ended in 2000 after the completion of the urban rehabilitation. In light of this experience, ADP realized that it would be necessary more comprehensive responses to guarantee the right to health and human dignity, even if drug users continue to consume drugs. Our aim go out and be closer to the drug users with the main objective of safer drug use. That means to provide healthcare even if drug users keep using drugs. So in 2001, ADP launched an outreach health program using mobile units, integrating a low-threshold methadone program with the support of the Ministry of Health and the Lisbon City Council. It was a total innovative program, both because of its proximity to drug users and because it was a mobile methadone program. It should be pointed out here that it was a very important legal facilitating factor to the acceptance of this approach at the time. The decriminalization of possession and consumption of all drugs approved in Portugal in the year of 2000. So the program covers the entire city of Lisbon at 5 spots with 6 schedules at each spot and operates all days of the year and is frequented by more or less 1,200 people in a daily basis. It is a program aimed at drug users who, for whatever reason, do not have access to community network services. And its main features of this program is easiest of access, prompt response, concern towards abstinence, symptoms and craving, healthcare, and abstinence of drug use is not required to be in the program. So in 2021, this is the main feature that I read before. In 2021, ADP was invited by the Lisbon City Council to set up and manage a drug consumption room, PCR, in Casal Ventoso that remained a center for drug trafficking and open-air drug use, although to a much lesser extent than in the past, about 10% of the number of users we observed in 1998. This slide shows the general objectives and interventions carried out by this facility. But I would like to point out that there are decentralized hepatology, general practitioner, and women's health appointments in the facility, in the DCR. Also in the 2021, Lisbon City Council invited ADP to manage health and drug-related issues among homeless people who are being housed in a shelter created that year with 130 places. This slide shows the alcohol and drug consumption room created within this shelter. It is the only shelter in Portugal with a program of this kind. So in short, two slides. In short, the strategy followed over the years by ADP has focused on promoting more aligned and effective intervention within the continuum involving individual and public health, human dignity, and social justice. In 2025, almost 5,000 people were served in the various ADP programs. Last slide. Just to final remarks, there has been a constant disinvestment since the beginning of the second decade of the year 2000 until now. And one thing that our experience has taught us that although it is important to have support for treatment and rehabilitation, it is also crucial to be aware that for various reasons, a large proportion of drug users do not access this structure. It is therefore essential to have responses that preserve human dignity and healthcare for active drug users. Thank you very much.
That's perfect. And thank you so much, Rodrigo, for, wow, what a journey. And also, I mean, I don't know, like for me, what strikes me is the range of services that have been put together, the pragmatism in trying to respond to specific issues at a specific given time, and how you've been able to adapt the services to whatever was arising at the time. But I think we can all agree that there's a common trend here in terms of funding and the dire lack of funding that we're facing for services and for the work that we all do. So we have about 15 minutes of Q&A. I'm very grateful to the panelists for sticking to the time. So please take the floor, introduce yourselves before you do so that we know who you are. But we have a little bit of time for questions or comments. So where's yours? Adria?
Good afternoon, everyone. Let me congratulate to the panelists for this excellent presentation. It was a really good discussion and shows the value of civil society in drug policy debates. I have a question. I might react my anyway. I have a question for the two members of representatives of the EU institutions here, which is precisely about. We saw a new regulation for the EU drug agency being adopted a couple of years ago. And that regulation we really welcomed it because it included a commitment to create a mechanism for civil society participation in the work of the agency to escalate it. And it really, there was a strong mandate by the EU legislators for that. And I wanted to inquire what is the current state of that mechanism. Is there going to be a concrete proposal soon for how it's going to look like, etc.?
I think Danilo from the trust agency left because he couldn't reply more in detail about this. But it's ongoing. So there will be, I think we can mention it, there will be a civil society platform that will also foster the exchange of information among civil society organizations, also allow to consult civil society on specific issues. I don't have the exact timeline, but I think there will soon be a web page on this, so it's upcoming. I will inquire as well for the more specific details and let you know. It's important in the process.
On our part, as the HDG, we know even less than what was shared here, so I am not able to share any more light on this issue. But we also are expecting probably through the discussions, which I will just touch upon later, on creating an implementation framework for the strategy. We expect that many things that maybe are up on the air right now regarding not only the UDA, but many things that are happening across the EU, we will try to streamline it a bit and be more informed about what is actually taking place.
Thank you. Any other questions or comments where anyone wants to share their own experience of what's happening in their own countries based on what's been discussed here? Yeah, Joanna?
Hello, I'm Joanna from the European Network of People Use Drugs, and also from MANAS, a collective based in Lisbon and the University of Lisbon. I would love to hear Magdalena's recommendations. And then, and then secondly, I would love to listen your opinion on the importance of participation of people who use drugs in policy and service design services.
Thank you. So, Magda, go for it. This is your opportunity, and then we'll go around on the participation of people who use drugs.
Thank you for the question. I'll gladly share, although you will not be surprised at all. So first and foremost, mainly at the national level is the recommendation to reform punitive drug policy, and I will constantly repeat, decriminalize at least the possession of drugs. We heard Pavel Bam yesterday for the second time in the position of drug coordinator, drug czar, as we like to call it, of the Czech Republic, who stressed this, that again, decriminalization is the fundament for all health responses, for access to health responses, and without that, people will really not they won't be able to access and benefit from whatever we as organizations, as health facilities can propose. So decriminalization as the first and fundamental step. Then to address comorbidities, health systems should guarantee that people who use drugs have access to prevention, diagnosis, treatment for HIV, hepatitis C, and TB. Elimination of healthcare discrimination. This is a huge one. This is difficult to track it sometimes, since it may not be embedded in the system as such, but a lot lies in people's heads and hearts. Expansion of harm reduction services, definitely, with the increased funding for them. I know we as NGOs sound like if we're asking for more money, but this is really, again, the fundament. Without that, we cannot really talk about the enjoyment of the right to health. It will stay at a limited level, or it will disappear for some particular groups, because the number of NGOs, the number of activists and groups that are willing to provide support often for each other without proper or without any funding within the EU countries is going down, and it is a natural process. So it is really not about NGOs becoming more wealthy, but really about sustaining the work and the ability to save people's lives. So without the increased funding, there will be not much that we all can do. Improved accessibility of OIT and also in the prisons for people deprived of liberty. Mental health services for people who use drugs, services tailored to the situation of the groups that have specific needs that I mentioned before. And at the pan-European level, really, we have to maintain the health-centered and rights-centered approach. And I'm therefore very curious about what you'll be sharing about the implementation and what can still be done at this point.
We're keeping the suspense on this for the
Yeah.
present.
Yeah.
I think you've noticed. I don't know if Liber, you
Oh,
want to
yes,
come back on the
yes, in
participation
our
of
organization, we have people with lived experience, and we have some actions in the DCR with people living with living experience. Actions that we have meetings and rules, and some of the rules or way of working in DCR, they are decided. We have meetings with people, but people with living. We have how do we say it? It's difficult to pay because there is no formal institutional way to pay. Now we are creating project sponsored by a corporation. Then we have our money, and then we can have some people with living experience to help us and to better to deal with the problem. But it is not easy in some way to have this formalized this kind of.
Thank you. I don't know, Leo, and
Yeah, I can
if you
go.
want, and then you see it.
Yeah. So to the question on the policy and services side of people who use drugs, I think it's cost effective. Everybody likes to talk about the money. It's cost effective, you know. You're also responding to instead of responding to what might happen. There was a lot of conversation yesterday and ongoing about responding to and foresight in the future and responding to what might happen. But when you are engaging people with living experience, you are responding to what is happening. So it's a lot more meaningful, and also it leads to less issues with implementation. You don't have to go back to the drawing board. You're kind of meaningfully engaging right from the start. So not only is it cost effective, but in terms of capacity and time, it's just effective. Also, most and more importantly, is leads to the empowerment and social integration of people who use drugs, but also everybody. And I'll quote my colleague Richie Healy, who's not here today, but we often talk about this reintegration of people who use drugs and how people who use drugs need to be reintegrated. And the reality is that a lot of people haven't been integrated in the first place. So when we talk about reintegration, we want to integrate people in the first place, including in policy, service design. And just quickly to the peer payment standards, for people who use drugs, there are a lot of best practices we can build from, including Canada, but now like Spain and England and Ireland. There are prototypes that we can look to for peer payment standards on how to pay people. So if you want to talk about that, you can.
Yeah, well, of course, I think it's very important to involve people who use drugs into policy making in the field of drugs. That's also at the European Commission level. We work also with the Society for Women on Drugs, which we can also, and we worked on it also in the drafting of the new drug strategy. And then society will be also a key actor in the implementation of the strategy. And I think Constance will talk more about the implementation framework, but that's the idea to have a framework for the implementation of the strategy with identifying also actors who will be in charge of implementing the action. And so this society is very important because you have the experience from the ground as well, which is very key.
Thank you. And I don't know, Constance, if you'd like to also share your experience.
Yeah, I could share our experience in Cyprus, which the challenge was because the last time that we drafted the national strategy was in 2001. And the problem is that in Cyprus, okay, we're a very small country, small numbers, and we don't have civil society organizations that are people who use drugs. So we managed to, let's say, encourage friends and families of people who use drugs to organize. But from one point on, it starts to negate the purpose if the national authority is creating an organization to have feedback. At some point, then there is a danger of negating the whole idea of why there is an NGO that advocates for the perspective of people who use drugs. So in our case, that was an actual challenge. We tried to reach out to people that we knew from our other experiences from other countries to use their experience, but it's not the same, of course. So yeah, just one extra challenge when the numbers are so small, like in our case, there is also that, but not an issue of not managing to respect and communicate with these people, but also to actually find and encourage them to be part of this process.
Thanks, and I think that goes back quite a lot to a lot of people might not be willing to identify themselves publicly as a person who uses drugs.
As a country, the stigma is more.
If it's small enough,
the fear is more.
Yeah, and that all the more reason to decriminalize and remove stigma. Judith, a very small comment, because then we'll actually go to the closing remarks from Konstantinos, and then you might have many more questions for Konstantinos. So.
Hi, Judith Yates. I'm a retired GP from the UK. I don't know how short it is because I could talk for hours, but we don't have decriminalisation in the UK. The UK, we have the highest level of drug-related deaths in Europe, as you know. In fact, Europe reduced their level of drug-related deaths when we Brexited and took our figures out of your figures. That's not just the harms of this may include the fact we don't have drug consumptionists. We have one. You spoke highly of our engagement with people who use drugs, which we do have, I suppose, but the voices of of all of us don't get through to in any sensible way to our central government. We don't have drug consumption rooms except for this token one in Glasgow, which I'm glad that's there because they had a spike of HIV with 500 new cases, which allowed that. But my city, I'm sorry, I will stop in a second. The National Crime Agency said there's never been a more dangerous time to use drugs. And this is not getting any better, it's getting worse, isn't it? We don't have safe supply. The supply is more and more uncertain. We don't even have easy access to drug checking in the UK. We have a little tiny bit, not nearly enough. We have nitazines causing 30 odd deaths in my city in Birmingham in the summer of 2023, and that's an ongoing. And we now have morphines, don't we? Again and again, it's more dangerous. We don't even have, as other countries have, any safe supply of cannabis. I mean, even Germany can manage to organise their cannabis supply, and in the UK we just have the police with battering rams breaking down warehouses and smashing up cannabis plants. So I'm just saying that, we do have some good things, and you mentioned our engagement with people who use drugs, which is there, but I'll stop.
No, thanks so much, Judith. I mean, I live in London and I hear you. It's frustrating, and that's why we have these spaces as well to uplift us a bit in terms of, we know there are some good practices out there and they actually are happening, and also to feel the solidarity for all of us who are still struggling for all of this. So, because when you have 5 minutes left, I want Konstantinos to be able to have enough time to tell us everything there is to say. You've got the floor. Thank you for being here.
Firstly, thank you very much for inviting us, or giving us the opportunity to have this role. And before anything, I would like to stress that we are here not only in our capacity as the Republic of Cyprus, but also as the presidency of the Council of the European Union, and by that we hope to show in this way that the support is there, even if unfortunately it was not able this time, I think for the first time, to co-sponsor the side event as the Council. So I think that the things that we're discussing today is just a significant show of the power of the EU approach on drug policy, which highlights the balanced approach, highlights evidence-based approach, highlights human rights at the center of the policy, and in which the civil society is not just a key partner, is an essential actor at every stage. And regarding the role of the civil society, I was thinking during all the presentations that it's a little bit like the development of us as humans. As a person, when you find yourself in a new situation whereby you are out of your comfort zone, and then you are required to deal with a new situation. You're required to find new ways to address the situation you are in. That is usually the way that a person grows, that a person matures, that a person manages to gain new traits and new capacities. And I think that is, if we zoom out and we think about societies and states, I think the civil society plays exactly that role. It takes the governments, it takes the institutions out of the comfort zone. And by putting us there, it pushes us to, look at things in a way that puts more reality, let's say, of the situation. And that also relates to the reason that Cyprus decided to have as a priority services in prison settings, for which we will have a side event, I think, in 1 hour, for which you are all invited. But it's not like Cyprus has excellent policies in prison settings. Far from it. But we feel, not me personally, I think we all feel that we should discuss the things that we are not good at. Because it's one thing to celebrate how much we have accomplished regarding incorporating the civil society in the policy-making processes and on drugs. But at the same time, it doesn't mean that we should not acknowledge how long is and how much is still to be done. And the one that not negate the other. You can be very proud or very happy for the level of cooperation, but at the same time you can feel that there is still a lot to be done. And I think today's side event has showcased this in a very clear way. There are things to be done, and I just wanted to say that Cyprus, and I think I speak on behalf of also the HTG, we are very dedicated in making sure that this cooperation flourishes, continues, strengthens, and drug policy always has the focus on the people that it's supposed to serve. So now, having said all that, I'm sure that people are interested also about the implementation of the strategy. So I will also mention some things because, you know, the discussions have not yet actually started even in the HTG. So I can share just our initial thoughts or even less than that, because we have to try to share some thoughts, some things with all the people involved, and we would like to share it, I mean, a bit formally with the CSFD also. But in our minds, of course, the common feeling at the HG was that the fact that we didn't have a comprehensive action plan, that was not the best end result of a very long and difficult process for the Commission to create the new strategic framework. But after feeling bad about it, we started to discuss between us that maybe this is an opportunity of giving ourselves the time to think about maybe a little bit differently about it. And why do I say differently? Because what did we used to have? We used to have a comprehensive action plan, which was a list of, as you very well know, a list of actions with a lot of people involved and responsible for many things. And I have used this example again. Cyprus is a very small country. There are actions that say member states should do that and that and that. And if something is not something that I feel that, you know, it will be difficult for me, then I can say to myself, you know, Germany will do that. You know, France will do that. So that just leaves us with an action plan that is supposed to mean a lot of actions and is very specific on actions to be made, but it lacks in the capacity of actually making sure that things are implemented, of ownership of things to be implemented, measurability of things to be implemented. So we are trying to imagine a different way of going about, not by creating an actual action plan like the one that we have on drug trafficking, but firstly making sure that 1,000 things that are happening right now all over the EU that relates to drug policy, but we don't know about it, should be streamlined and used as concrete evidence of what is taking place. The EUDA has a very pivotal role to play here, because there is evidence of things that are happening in member states as we are speaking, but these are not included in the drug report. These are not included anywhere. Not even the HTG is getting this knowledge of where we are. So there are a lot of aspects of the strategy that, using the data that we are already giving the EUDA, we can be much better informed of what is actually happening. Using also other aspects. As you know, one of the issues that we had is that Home Affairs deals with internal security. There is DigiSante, which is the health aspect of, but DigiSante does not actually, is not involved in as concrete way as we would like. It's not like we don't talk with them, but there is a lot of things to be learned to the member state by what DigiSante is doing. And I don't want to take more of our time. So having an idea of what's happening is a very significant aspect of this implementation framework. And of course, and I will not say more on that, finding a way of, okay, what are the new things that we need to push? What are the aspects of we are lacking? And again, we need to find a way because not all the member states are at the same levels. Cyprus is not at the same level as other countries regarding their consumption rules, regarding opioid agonist treatments being available in prison settings, for instance. Other member states are behind in other aspects. So we need to find a way without just making everything the same, pushing things a step. And I will not say anymore. I hope I didn't share more than I was.
And this is being recorded.
No, I think this is the thoughts that we share with everybody. I'm only kidding. So thank you again for giving us the opportunity to share our thoughts on these aspects and for the very important side of it.
Thank you so much, Konstantinos, and thanks so much. For coming, and I wish you a great rest of your day and week here in Vienna. And please do support the public health resolution. Reach out to your member states and push them to support inclusion of prevention, harm reduction, treatment, recovery in the resolution. Thanks to you all. Have a good rest of the day.